Assalamu alaikum everyone. I'm Bushra Rasheed. I'm a medical intern from Al Faisal. And today I'm going to be giving you guys the lecture about GIT pharmacology practice questions. I do want to start off this lecture by saying that if at any point you guys have any questions, you can just stop me and ask away. I will try my best, inshallah, to answer them. I've also included my phone number and my email address in case you'd like to contact me regarding one of the questions, if you have any confusions or if you'd like to give me any sort of feedback, anything at all, you can feel free to reach out to me. Okay, so I do want to start off by giving you guys a brief, I just want to revise the antiretroviral drugs with you guys before we move on to the actual questions. I was told that these weren't explained very well, and that's okay. That's what we're here for. So I'm just going to go over, the antivirals for both hepatitis B and hepatitis C very briefly, and then we'll start, inshallah, the lecture. So the first one that I want to talk about is interferon. Now, interferon is used for both hepatitis B and C, although I think in the lecture it was mentioned more so for B, but it's important to know that they're actually used for both B and C. What is the importance of pegylated interferon? There's this group that's sort of added on top of the interferon alpha. It's called the PEG moiety, right? And the whole point of this moiety is that it increases or it makes the pharmacokinetics of interferon alpha better. It just increases the absorption time so that it's released slowly, and then the duration of action for interferon alpha is better. Not really important, but just something that you might want to know. So the mechanism of action of interferon alpha, something to note, another thing, sorry, important to note for this is that interferon alpha is actually released by your own body. It is released by the cells. It's released by the hepatocytes that are going to get attacked by the hepatitis viruses. But why do we give interferon? Is to reinforce the effect of our body, right? So we already know that it's antiviral. It has an immunomodulatory effect via the inter and intracellular mechanisms. The most important thing that it does is that it's going to inhibit viral protein synthesis, right? Not only does it inhibit proteins, it's also going to break down the RNA. So the breakdown of RNA. And the third thing that it's important that it really does is that it increases the expression of MHC class 1 molecules. Now, what are MHC class 1 molecules? They're basically these sort of receptors on top of cells. All cells of our body, all the nucleated cells and platelets in specific, carry MHC class 1 molecules. They're receptors on the outside of the cell, and they're basically responsible for displaying intracellular pathogens on the outside. So if there was a virus or if there was a bacteria that went inside the cell, what happens is that they get attached to the MHC class 1 molecules. These molecules are then displayed on the outside of the cell. And then a T killer cell or a CD8 plus T killer cell is going to come, recognize the virus, recognize the bacteria, and then it's going to cause, induce apoptosis or induce destruction of the cell that was displaying this pathogen. So yeah, that's very important in cells that are infected by viruses specifically. Indications for interferon alpha, it can be used as monotherapy, but only for acute hepatitis C and hepatitis B. If you had chronic hepatitis C, you would not use monotherapy because when it's chronic, you need something that's a little bit more aggressive. So in this case, you would want to use it as a combination treatment. So you combine interferon alpha, you take a few other hepatitis C drugs, and then it's usually given as a concoction of medications. Contraindication would be decompensated cirrhosis. So in that case, your hepatocytes are quite damaged on their own. You're not going to want to give something else that might be a little bit tricky to deal with in this scenario. Certain psychiatric conditions, pregnancy, autoimmune conditions, and then leukopenia and thrombocytopenia is also like when we don't necessarily give interferon alpha in these conditions because they tend to worsen these conditions. Adverse effects include flu-like symptoms, bone marrow suppression. Again, we talked about the leukopenia, thrombocytopenia. That is why they actually cause bone marrow suppression. So we don't want to give it to patients who already have these because they're going to get even worse. Certain CNS conditions such as depression, seizures, we prefer not to give interferon alpha, induction of autoantibodies, and then patients that have a myopathy. Something else that I want to note is that these tables are very comprehensive. So if you were to just memorize one of these, actually not one of these, like all of the ones that I've included in this presentation, I would want to say that you would be in a very good position to answer questions in your exam. Okay, Moving on, now we're talking about hepatitis B specific antivirals. So we have two different classes of drugs. We have tenofovir, and in the same class, we have adifovir. Now, both of them have the same suffix, so fovir, and this is how we're gonna like group them together. What these do is that they're nucleotide analogs. Now, we have nucleotide analogs, and then we have nucleoside analogs. What is the difference between a nucleotide and a nucleoside? A nucleotide is made up of three components or three subunits. One of them would be a nitrogenous base, right? Of course, this is where you have adenine, thymine, all of those nitrogenous bases. Then you have a pentose sugar. And then the third thing you have is a phosphate group. These three together make a nucleotide. What is a nucleoside is when there's no phosphate. So you only have the nitrogenous base, you only have the pentose sugar, and that is a nucleoside. So how do these work? So when you ingest tenofovir, they're gonna get this, by the way, is an adenosine analog. It might be like important for you to note that it's adenosine specifically. What happens is tenofovir is not already phosphorylated. You're gonna take it in, it's gonna get phosphorylated in your GI tract. Once it gets absorbed, it goes to the hepatocytes. It's gonna get phosphorylated now to a triphosphate, okay? And there it binds to the DNA polymerase. What it does is that now that it's bound to the DNA polymerase is no longer able to act on the viral cells. And so that is why there is a premature termination of DNA transcription. So yeah, there's no more transcription occurring now since one of these molecules is attached to the polymerase and stopped the transcription. Indications for this would be chronic active hepatitis B and HIV. Adverse effects include nephrotoxicity, headaches, abdominal pain, and possible disease exacerbation. It's not very common. It is quite rare. So I would say it's not very important for you to note, but I think the nephrotoxicity, the headache, and the abdominal pain are more important for you guys to know. Then we have the other group, which is the nucleoside analogs. We have the lamivudine, which is a cytosine analog. We have telbivudine, which is a thymidine analog, and then entecavir. All of these inhibit reverse transcriptase. What are the indications for these? Chronic active hepatitis B and HIV, the same as the group above. Now, what are the adverse effects? We have occasional GI symptoms. We have fever, headache. I feel like headache is something that abdominal pain is something that you can sort of lump anywhere, you know? But again, they're not that common. And super rare side effects would be vasculitis, neuropathy, and neutropenia. These would be important to know because, you know, the things that are exquisite, the things that are rare are the ones that end up getting tested on the most. So I think these are the ones that you should really know about. Now, before we move on to the hepatitis C antivirals, I wanted to quickly talk about the life cycle of a hepatitis C virus. So what exactly ends up happening when an HSV virion comes into contact with a hepatocyte? The first thing that happens is that it binds to the receptors on the hepatocyte, right? So it binds to the complementary receptors, and then endocytosis occurs. This entire virus gets engulfed by the cell membrane, a piece of it breaks off, and then here we have a virus engulfed by a piece of the cell membrane. What happens next is fusion. So do you see the membrane around the virus? This will fuse with the cell membrane or the vesicle, the membrane of the vesicle, and then the material inside, the genetic material inside comes out. All of this is able to go into the cytoplasm. And since this is a hepatitis C virus, it's RNA. This is not DNA, it's going to be RNA. Now the RNA is within the cytoplasm, it's naked, it's inside. What happens to this RNA next is translation. So it goes to the rough endoplasmic reticulum, it goes to the ribosomes, right? And then translation starts to occur. What the product of this translation is one single really long polypeptide. Now we have something known as NS3-4A proteases. What is a protease? Something that will break down a protein, right? So these proteases will take the really long, it's just one singular really long protein that is formed off of the RNA of hepatitis C, right? So it's going to take this really long protein, it's going to cut it into lots of different segments, and now you have the essential proteins that are responsible or necessary for a hepatitis C virus to survive. What we do is we'd like to give NS3-4A protease inhibitors. Now, what are these inhibitors? These inhibitors will include glecaprevir and paratoprevir. I have these written down. There's no way I'm memorizing these. They're difficult. But anyways, you don't even really need to memorize the actual names because protease, and then provir at the end. They sort of go together. So whenever you have any name in the MCQ options where it says provir at the end, there you go. You know that this is an NS3/4A protease inhibitor. It's not going to let the polypeptide cleave at different sites, so proteins are not made, because of which the whole virus is not going to be able to get assembled, right? Next step, we have these membranous sort of webs, okay? And these come together when all of the proteins that we just translated, they sort of come together to form this replication complex. And the most important one, the most important molecule that is responsible here would be the NS5A. Now, this molecule, let me give you some examples of what the NS5A inhibitor would look like. So we have Lepidosvir, we have Preventesvir, and then Elbasvir. Now, for all of these, since this is NS5A inhibitor, all of them sort of have an asvir in them, right? The A, and that will help you remember these. So these inhibitors are not going to let this membranous web come together. So none of the replication, or so none of the different molecules of the hepatitis C virus are going to be able to assemble together. So you're not really, there's no replication, there's no assembly, and it's inhibited at this step right here. Next, we have the NS5B RNA polymerase. Now, this molecule is necessary for the RNA replication of the virus. When you have inhibitors for this, RNA replication won't happen. You're not going to have more RNA for future HSV viruses. And yeah, assembly is not going to take place either. NS5B inhibitors include, the most important one actually is the sofosbuvir and the dasabuvir. Now, both of them have the same suffix, which is buvir, and that starts with a B, and then you have the NS5B RNA polymerase inhibitors. So this is going to help you remember this. Yeah, once everything happens, usually the HSV viruses will get assembled, and then they're able to leave the cell. But if you're able to stop any one of these processes, that won't happen, and so you're not going to be able to get the virus or the spreading of the virus. So here's the table. Okay, the first, actually, we kind of skipped this, but the ribavirin is also another important agent used against hepatitis C. It's a guanosine analog, so nucleoside inhibitor. It's the competitive inhibitor of IMP dehydrogenase. Now, when you don't have IMP dehydrogenase, you don't really have the conversion of IMP to GMP. And when you don't have that, you're not going to be able to create RNA. So you're inhibiting the synthesis of RNA. Indications for this are adjunct in combination with other treatment for hepatitis C that is refractory to direct-acting antivirals. So yeah, this is not usually the first line. We prefer direct-acting agents or antivirals first line, but this is something to keep in the back of your mind for when the direct-acting ones are not working. This is also used for viral hemorrhagic fever, RSV. You don't need to know that exactly. But the adverse effects for this are very important. So ribavirin will cause hemolytic anemia, and it's very, very highly teratogenic. It's not at all prescribed to patients that are pregnant. And then nausea, which nausea is like really not that big of a deal. It is to the patient, but it's like in terms of questions, nausea, they don't really test on that. But hemolytic anemia and teratogenicity is very important for you to note. Okay. Next, we move on to direct-acting antivirals. So we have glecaprevir, and then Razo. This is not really mentioned in your slide. I wouldn't really think about that, honestly. Glecaprevir, and then the next one we have is peritaprovir. Now, both of them end in the suffix previr, right? So that means protease inhibitor. And that means it's NS3/4A protease inhibitor. So yeah, glecaprevir in general is used for chronic hepatitis C. It causes headache, fatigue, nausea. Peritaprovir used for, again, chronic hepatitis C, and specifically genotype 1 or 4, right? It has some of the vague side effects like headache, fatigue, nausea, insomnia, but then pruritus and allergies or different skin allergies is something that distinguishes this from other protease inhibitors. And yeah. All right. Next, we move on to the NS5A polymerase inhibitors. For these, you're supposed to know 3. We're not going to talk about this. We're going to talk about elbasvir. We're going to talk about lepidosvir, and then the fibrinosphere, right? Again, it's NS5A, so all of them have an S-sphere, a sphere, a sphere. Okay, that's how you sort of know. They say that the exact mechanism of action is not really known. We sort of do have a brief idea of how it works. It sort of works on the membranous web kind of a component that helps with, sorry, that helps with the assembly of all of the different components of the HSV itself. But how it helps exactly, that is unknown, yeah. What else? Prevention of replication, yeah. Used once again for chronic hepatitis C, chronic hepatitis C, chronic hepatitis C. I'm pretty sure you don't need to know about the genotypes. It wasn't mentioned in your slides. As long as you know that it's chronic hepatitis C infection, that's enough. We know that it's used, we know that Elbasivir causes diarrhea, nausea, all of these other things, which we don't need to know this because this is the one that we're skipping, and then headache, fatigue. So pretty much it's like, they're kind of similar. I think the most important ones for you guys to know would be the ones that are specific, not these non-specific ones. Okay, and lastly, we come on to the NS5B inhibitors, which is dasabuvir and sofosbuvir. So B, that's a very good sort of, we know that that's how it works. This is an RNA-dependent RNA polymerase, which is necessary. Once you inhibit that, you're also going to inhibit or disrupt RNA synthesis at its root. And because of that, you're not going to allow for HSV replication to occur. Once again, pretty much the same side effects, fatigue, headache, insomnia, pruritus, asthenia, and then nausea. Pruritus or skin allergies would be an important one to know. Okay. So we're done with the antivirals pretty much. This is another table that I've included. This is for the antiemetics. I'm not really gonna go over this in detail, but I've included this here regardless because I know that not everyone has the AMBOSS subscription. So you know what, it's fine. You can just quickly go over this. If you wanted to recap the entire lecture, it's very, honestly, this table is pretty much all you need to know for the antiemetics lecture, but yeah, something important for you guys to note. All right, so we move on to the first question. So we have a 60-year-old man that comes to the physician for the evaluation of nausea over the past week. During this period, he has also had several episodes of non-bloody vomiting. Last month, he was diagnosed with stage 2 Hodgkin lymphoma and was started on a plethora of chemotherapy drugs. You don't really need to know which ones, but yeah, these are the ones that he was started on. His temperature is 37, which is pretty much okay. His pulse is 95, that's within normal as well. Blood pressure is 105, a little bit on the lower side. Physical examination shows cervical lymphadenopathy, which is to be expected with Hodgkin's lymphoma. And then there's also some hepatosplenomegaly. The remainder of the examination shows no abnormalities. The patient is started on appropriate medication. 2 weeks later, he develops headaches and states that his last bowel movement was 4 days ago. Now he's having headaches and he's talking about the fact that he's constipated because 4 days is way too long of a period of time to go without bowel movements, right? Typically, you're supposed to have one every day or every other day, but he's had one 4 days ago. The patient was most likely treated with which of the following medications? Okay, so which of the following medications? So this patient right here had, yeah, so he has lymphoma. He has had lots of chemotherapy, and now he was treated with some sort of an antiemetic, right? Because I'm sure chemotherapy is definitely going to induce some sort of vomiting. So he was treated with one of those medications. Now, which ones was he treated for him to have constipation and headache? Which one do you guys think? All right, somebody said F. So F is a serotonin antagonist, which is correct. Excellent. Now we're going to briefly talk about all of the different side effects for each of these medications. If you were to have a muscarinic antagonist or an anticholinergic such as scopolamine, you would most likely, first of all, those are not really even used for chemotherapy-induced nausea and vomiting, CINV. That is more so used for motion sickness, right? For vestibular causes of nausea and vomiting. And not just that, anticholinergics have side effects such as mydriasis, which is dilation of your pupils, sorry, tachycardia, and then urinary retention, which he's having none of these. The next we have is a neurokinin antagonist, right? So the neurokinin antagonist most likely will give you fatigue and hiccups. You're not gonna get constipation. You're not going to get headaches with neurokinin antagonists. Next, we have histamine antagonists. So first of all, antihistamines are more so prescribed for vestibular nausea, which again is motion sickness, or if you were to have, other vestibular causes could be labyrinthitis, it could be Meniere's disease, etc. And then antihistamines are more so prescribed for hyperemesis gravidarum, which hyperemesis, when you're vomiting too much, gravidarum, which is during pregnancy. So that is when you give them antihistamines. And antihistamines have the side effects of sedation and confusion anyways, so we're not really thinking of this in this scenario. GABA A agonists are going to give you confusion, respiratory depression, so we're not thinking of that. Dopamine antagonists are more so given, first of all, dopamine antagonists, such as metoclopramide, we don't really prescribe these anyways because they do have quite severe or quite serious Parkinsonism effects or extrapyramidal side effects. So we don't want to prescribe them anyways. They're usually not first line. And they're more so prescribed for hyperemesis gravidarum, not really for chemotherapy-induced nausea vomiting, right? So the side effects of dopamine antagonists will include fatigue, diarrhea, and depression. And lastly, we have serotonin antagonist, which is the correct answer. You're going to get constipation, headaches, and very rarely elevated liver enzymes. Okay, so just a brief summary of the entire sort of system. There's three places in your brain, or three sort of areas that will affect or send signals or stimuli to the vomiting center. The first one is the vestibular system, right? Which is the vestibulocochlear system. It only has muscarinic receptors and histamine receptors, right? H1 receptors. So if you were to have vestibular causes of nausea, which could be motion sickness, which could be Meniere's disease, for instance, you're going to want to give either anticholinergics, such as scopolamine, or you're going to want to give antihistamines, which is diphenhydramine, promethazine, etc., right? So that's the first system. Next up, we have the nucleus tractus solitarius, which only has neurokinin receptors. And if we suspect that this is the part that's getting affected, we would prefer to give something as aprepitant, which this is not very high yield for you guys to know, but it's good to know anyways. And then the last the last sort of trigger or the stimulus that provides stimulus to the vomiting center is going to be the chemoreceptor trigger zone, which is present within the area postrema, and the area postrema is in the fourth ventricle. So this has all sorts of receptors on it. So it has dopamine receptors, it has H1, it has muscarinic, serotonin receptors. The vagus nerve itself has serotonin and muscarinic receptors. And then the stomach has dopamine receptors as well. All of this dopamine, this serotonin, this muscarinic, all three of these are they're kind of known as peripheral emetic areas, versus the chemoreceptor trigger zone is central, right? So once you give something like a dopamine receptor antagonist, such as a metoclopramide, you're inhibiting not just the central dopamine receptors, you're also inhibiting the peripheral ones in the stomach, right? Next we have the serotonin antagonist. We know ondansetron, and yeah, that's pretty much it for this slide. Now we can move on. All right, next question. 2 weeks after starting chemotherapy with etoposide, a 66-year-old man with small cell lung cancer comes to the physician because of a persistent nausea and vomiting. His symptoms improved significantly after the administration of metoclopramide. This patient's symptoms were most likely due to the effect of chemotherapy on which of the following structures? So the answer is E, area postrema. Yes, yes, it is E. Thank you. So, let's go over each of the options one by one. Okay, so first of all, we know that this is chemotherapy-induced nausea and vomit, right? So vestibular nerves we know are not affected by chemotherapy. We know that vestibular causes would include motion sickness, would include Meniere's disease, labyrinthitis. We're not thinking of that. Intestinal smooth muscles, this is more so like when you have certain situations that affect intestinal motility, such as Hirschsprung disease, which is in babies, such as paralytic ileus, and like these conditions can cause nausea, vomiting, but we're not thinking of them because this is chemotherapy, right? The vagus nerve, yeah, the vagus nerve will take it to the area postrema, but truly the most important structure for this is the area postrema itself. And then the cerebral cortex, we're not thinking of that exactly because the cerebral cortex is only responsible for psychiatric causes of nausea and vomiting. You know, if you were to have, okay, I can't think of a condition, but any sort of psychiatric condition that would give you nausea or vomiting would be controlled by the cerebral cortex. Okay, so this is pretty much the same diagram. We've already gone through this. Let's move on to the next question. 1 minute, please. All right. A 47-year-old man with a history of hypertension, depression, and osteoarthritis reports having epigastric abdominal pain for the past several weeks. So this is a very typical sort of a USMLE question for students that are considering the US pathway. Um, uh, this is like we're going off topic a little bit, but if you still are considering the US pathway, there's like a lot more factors to consider now than there ever were before. You know, considering the new president and considering, you know, all the different travel bans that are possible. Anyways, it's just a brief sort of introduction to the topic because this is something that you should keep in mind when you are pursuing either the US pathway or you want to switch to another sort of pathway. Just something to know. Anyways, we're gonna move on. Osteoarthritis and epigastric abdominal pain. These are buzzwords that clue you in that this patient was most likely taking an NSAID, right? Immediately, they're buzzwords because they give you a very immediate impression. But this patient was most likely on NSAIDs because of his joint pain, and now he's having epigastric pain because you know why, right? All right. Where were we? Oh, sorry. Um, Okay, yeah. The pain is constant and worst at mealtimes and is sharp and non-radiating. Non-radiating is good and sharp is good because these kind of words will give you the impression that this is not a cardiac cause. Cardiac pain is not sharp, it's heavy, and it usually will radiate as well if it's typical, right? He has occasional nausea, but reports no heartburn, emesis, chest pain, melena, hematochezia, or unintentional weight loss. So, you know, we're ruling out red flags to we know that there's no nothing urgent going on. He has no known drug allergies, and his home medications include amlodipine, sertraline, as well as naproxen. There you go, which he has been taking for the past 2 months because of knee pain. Vital signs are normal. Physical exam is noted for mild epigastric tenderness. Normal rectal examination with a brown stool. CBC is fine. Which of the following is the next steps most appropriate for this patient? So, what do you think is the answer? E. The answer is E. Very good. So let's go over the options one by one. We could either start sucralfate twice a day, which we know that sucralfate is what? It has sort of a protective mechanism where it forms this lining on top of the ulcer to prevent pain for the ulcers. But sucralfate was not really going to work here because, you know, the NSAID is still getting used. This is not a very, what would you call it? This isn't going to heal the ulcer. It's going to provide relief to the patient, yes, but this is not something that's going to heal. This is not something that we're thinking about long term. Also, the question sort of says, which of the following is the most appropriate next step? So truly, you can't really give sucralfate until you diagnose him with an ulcer right there and then, right? And to diagnose somebody with an ulcer, you're going to have to do a scope. And we haven't done either one of those. So you can't really go directly to the sucralfate, right? So we're not thinking of that. Um, yeah, you're so right. It's best to treat the underlying cause because sucralfate is treating the symptoms more than treating the underlying cause. Yeah. The next option is initiate metoclopramide before meals. Metoclopramide is a dopamine antagonist, and as I mentioned earlier, dopamine antagonists do have a lot of other side effects. So we really don't want to give them first line, and we really don't want to give them at all, if possible, truly. If there's something else we can do before metoclopramide, we really do prefer that. Prescribe a 2-week course of bismuth, tetracycline, metronidazole, and lansoprazole. Now, this is the treatment for H. pylori, right? Nowhere does it say, first of all, that he has H. pylori. Nowhere does it say that he was tested for H. pylori. And nowhere does it say that this is a duodenal ulcer, which are all of these are, quite sort of telling that this is a duodenal ulcer. And in those cases, we treat the H. pylori. In fact, it mentions here that it's worse at meal times. So this is more so a gastric ulcers, and gastric ulcers are not always caused by H. pylori. It's more so like I think 40%, and you cannot prescribe this treatment until you do an H. pylori test, right? So this is not the most appropriate next step. Recommend a esophageal-gastro-duodenoscopy. Now, these kind of scopes are more so reserved for patients that have red flags. What are certain red flags? Red flags can include elderly people, so 60 plus age group. It can include previous ulcers. It can include previous GI bleeding, unintentional weight loss, melena, hematochezia, everything that's sort of already mentioned in the question. We don't have any of these, so we don't need the scope. Discontinuing naproxen is the most appropriate next step. All right, next question. A 28-year-old man comes to the physician because of a 3-month history of upper abdominal pain and nausea that occurs 3 hours after eating and at night. The symptoms actually improve with eating. So that's very telling of, you know what? After eating, he often has a feeling of fullness and bloating. He's had several episodes of dark stools. There you go. So he's having melena, which means that he's having some sort of upper GI bleeding. He has smoked 1 pack of cigarettes daily for the past 10 years, which that's not very good, right? That's a 10 pack year history. And he drinks 2 to 3 bottles of beer on most weekdays. That's not, again, 2 to 3 beers on most weekdays. If they had said weekends, usually we can rule that out as, okay, that's not a lot of beer. But if he's consuming 2 to 3 glasses or bottles of beer on most weekdays, which is pretty much the entire week, that's pretty bad. He takes no medications. He's 5'4" tall, and he's 86 kilograms. BMI is 33, which is quite high. Obesity, we know, is one of the risk factors, right? His temperature is 36, which is fine. Pulse is fine. Blood pressure is okay. Epigastric tenderness with no regarding or rebound tenderness. Now, why do we want to know about rebound and guarding? Because these are signs of peritonitis. We know that there's no peritonitis, which means that there's no perforation. Because if you were to have an ulcer, and God forbid the ulcer perforates, now the bacteria is going to spread outside the GI tract, go into the peritoneum, and give you peritonitis, which that has a very bad prognosis. And so it's good to know that we already know in the question that there's no guarding, no rebound tenderness. All right. Bowel sounds are normal. Which of the following interventions is most likely to be effective in improving the patient's symptoms? Duodenal ulcer B. Excellent. So this is a duodenal ulcer. Why? Because the symptoms improve with eating. We know that the pain of duodenal ulcers decreases with eating. So D. When you eat food, decreased pain for duodenal ulcer, increased pain for gastric ulcers. Okay. And now that we know that it's truly a duodenal ulcer, 90 to 95% of all duodenal ulcers are caused by H. pylori. So, we don't even really need to do a test in this case. We can easily prescribe the quadruple therapy to this patient. Now let's go over the options really briefly. Cessation of smoking and alcohol consumption. For sure, he definitely needs to stop smoking and stop or decrease actually the amount of alcohol consumption. But they talk about the most likely to be effective in improving the symptoms, and these things are more long-term, if you were to stop smoking and if you were to stop your alcohol consumption, this would help you in the long term. This would help you prevent the recurrence of an ulcer. It's not really going to do much for the ulcer that you already have right now. Cholecystectomy, no. We're not suspecting a gallbladder issue. We're not suspecting cholecystitis, and so we're not even, that would present with positive Murphy sign, that would present with right upper quadrant tenderness, possibly jaundice. We don't have any of these symptoms here. Exercise and weight loss, that is more important for GERD than it is for ulcers, so it's not that necessary. Pantoprazole will definitely, that again is more so, more important for GERD. Pantoprazole is gonna give a relief to your symptoms, a temporary relief, but it's not, it's not really the most important thing that we can do for this patient. Quadruple therapy is. All right, a 47-year-old man with GERD comes to the physician because of severe chest pain and belching after meals. He has limited his caffeine intake, which is good. You should do that for GERD. And he's been avoiding food close to bedtime, which is also good. They do a scope and esophagogastroduodenoscopy, and it shows erythema and erosions in the distal esophagus. So there's GERD-associated esophagitis in this patient, which means that this is severe. This is no longer just mild GERD, this is quite severe. And he's already done some of the things. He's been avoiding food close to bedtime. He limited his caffeine intake, and he's still having these symptoms, which we're not thinking about mild to moderate. We are thinking severe GERD, right? Which of the following is the mechanism of action of the most appropriate drug? E. You're right. So A is enhancement of the mucosal barrier. That's something that bismuth or sucralfate would do again. But that's not really, treating. That is more so treating the symptoms, not really the underlying cause. So we're not thinking of that, right? Inhibition of dopamine receptors. Once again, we don't really give dopamine antagonists until it is quite, quite severe. It is severe in this case, by the way, but we have other things that would work better. Why not do those first? Dopamine antagonists are more so for refractory cases. Refractory means something that is not treated by the first line. So if the GERD does not get treated by PPIs, we're going to consider dopamine antagonists. Neutralization of the gastric acid, that's antacids, and antacids don't really do the job fully. And antacids are preferred for mild to moderate anyways. Inhibition of H2 receptors, antihistamines once again are preferred for mild to moderate GERD. But this patient has severe GERD, and antihistamines are not first line anyways. They're preferred to be second or third line. So inhibition of the ATPase is the most likely answer. We're just gonna go over this really quickly. Give me 1 second. Okay, so the first thing that we can see here is on the left, sucralfate and bismuth, which is giving you a protective lining on top of the ulcer to help with pain relief. Now, this is good. It's definitely going to help with pain relief, but it's not really, we're not really doing anything for the substance that's causing the ulcer, which is the gastric overproduction, right? Then we have the PPIs, which are known to inhibit the hydrogen potassium ATPase. These include all of your prazoles, and once the hydrogen potassium ATPase is inhibited, no H plus ions or actually very less H plus ions are secreted into the stomach, which is not, it's going to give you some time or give some time to the ulcer for the ulcer to heal. If the acidity is less, we have antacids which neutralize the H plus, which again, but antacids don't really do that great of a job. It's definitely not comparable to a PPI. Next, we have misoprostol, which is a prostaglandin analog, which goes and binds to its receptors, which both misoprostol and octreotide, which is somatostatin analog, both of these are going to go to their respective receptors, and they activate the same pathway, which is the GI or the G inhibitory pathway. And this is responsible for inhibiting the CAMP. So they're going to activate these receptors, which cause more inhibition of the CAMP. And when there's less or no CAMP, the hydrogen potassium ATPase will not get activated, right? So it's not going to produce as much hydrogen, which is good, which is exactly what we want. Next, we have ranitidine, cimetidine, famotidine, which are all antihistamines, which are going to block the H2 receptors. The H2 receptors work using the GS pathway, which is the G stimulatory pathway, which will go to the CAMP, stimulate this CAMP, which goes and stimulates hydrogen potassium ATPase. When we block this with the help of antihistamines, all of this pathway is blocked. Simple as that. Next we have the vagus nerve, which the vagus nerve secretes two things. It secretes acetylcholine, which goes and binds directly to its receptor, GQ pathway, which will activate the IP3 calcium pathway, and then we have stimulation of the ATPase. But if you inhibit the vagus nerve, which can be done by a vagotomy, otomy means to cut. So you're technically cutting the entire vagus nerve. You're not going to have any of this. All of this will be inhibited. The vagus nerve also secretes GRP. Sorry. It also secretes. Yeah, so it also secretes GRP, which is responsible for activating G cells, which produce gastrin, which go and bind to the receptor, right? Which the entire pathway is the exact same, activates ATPase. We want to inhibit this. A vagotomy would inhibit this. We don't have GRP. We don't have as much gastrin to go and act here. We don't have as much of activation of this pathway. All right. What else? That's pretty much it. If you were to have atropine, which is an anticholinergic, you could technically inhibit this, and atropine would also work to inhibit the ATPase. All right. A 33-year-old man comes to the physician because of a 2-month history of burning epigastric pain, dry cough, occasional regurgitation. Patients that have epigastric pain, we know what this is, right? We know that this is most likely GERD. Why do patients with GERD have dry cough? Do you have any idea? Yes, you're so right. So the acid begins to irritate the esophagus, when there's regurgitation, the acid can go all the way up to your even larynx. And it can cause dry cough, and it can cause a burning sensation even in your throat. And there you go, occasional regurgitation. The pain is aggravated by eating and laying down, which there you go. This is GERD, right? If we talk about lying down, the acid is there's a reflux of the acid because of the lower esophageal sphincter not constricting properly. Physical examination shows a soft, non-tender abdomen. Upper endoscopy shows hyperemia in the distal third of the esophagus. So there is some sort of esophagitis associated right here. Which of the following drugs is most likely to directly inhibit the common pathway of gastric acid secretion? So we have all of these compounds. So we have all of these compounds which do inhibit gastric acid secretion in one way or another. Which of these will do it directly? So the answer is lansoprazole. Now, lansoprazole, we know, is a PPI, right? And a PPI is a proton pump inhibitor. It acts directly on the hydrogen potassium ATPase, right? D, perfect. Pirenzepine is if I'm not mistaken, and this is a anticholinergic. Anticholinergic, we already know. Let's go to the previous picture. I'm not able to. There you go. So we have acetylcholine here, right? So anticholinergics would block this receptor, which there's a whole pathway associated in blocking the ATPase. And yeah, if it doesn't work out, it's not direct. We're talking about direct. What's next? Famotidine, hydrogen, sorry, I keep saying hydrogen, no, sorry. Histamine. The antihistamines also don't do it directly. There's a whole pathway or a whole mechanism. Aluminum hydroxide is an antacid, which we know that it's not acting on the pump. It's not inhibiting the secretion of acid. It's more so neutralizing the secretion, the acid that's already been secreted, right? Sucralfate, never, obviously not. And octreotide, of course, not either. Octreotide goes through an entire process as well. This is another picture that talks about the same thing. Don't need to go over this again, honestly. All right, next question. A 60-year-old woman with a history of depression and obesity is concerned that the ibuprofen she takes for her chronic arthritis-related knee pain, which is 400 milligrams 3 times a day, is increasing her risk for GI bleeding. Nowadays, the patients that you see in clinic are actually very aware of these kinds of things. So it's very common for you to get a patient who already knows about these things, who already is anticipating it, which is honestly so nice to see. Um, yeah. Other efforts to relieve her pain have been ineffective, and she has declined knee surgery. She wants to continue the ibuprofen, but lower her risk of bleeding. She also takes mirtazapine, a daily multivitamin, and Docusate for occasional constipation. She denies any abdominal pain or symptoms other than constipation and has never had any GI bleeding, which means that she's probably never had any coffee ground emesis, she's probably never had hematochezia, she's probably never had melena. Which of the following management strategies is most effective or most appropriate to reduce the patient's risk for GI bleeding while continuing to alleviate her pain? D, add misoprostol. It's actually not D, it's actually A. Now, why is that? Lower the ibuprofen dose to the lowest effective dose. I know it sounds like you can add misoprostol and you can add omeprazole, but the thing with that is that those are usually reserved for very, very high NSAID concentrations. We don't prefer to add anything, if the NSAID dose is relatively low, which in this case, it's not very high to begin with, right? If she can lower the dose, that's even better. Omeprazole and misoprostol are definitely going to give you a certain amount of protection, but if the NSAID dose remains the same, it's not the most effective thing to do. So lowering the dose is the most effective thing to do. Um, so yeah, that's why A is the answer. Um, what else? Replace the ibuprofen with an equivalent dose of meloxicam or an equivalent dose of diclofenac. So, the thing with that is diclofenac and meloxicam are still NSAIDs, right? Meloxicam specifically is more COX-2 specific than it is COX-1. So while it's not the worst, you still would have what do you call it? You still would have a very high risk of GI bleeding. So we're not thinking of those options either. And they do talk about equivalent dose. We don't want an equivalent dose. We want it to be lower, right? And yeah, that's pretty much it. And omeprazole and misoprostol, just to add on to this, these are mostly given to patients who have already had an ulcer in the past, who've already had bleeding in the past, right? And patients who are very, very elderly, like 65-year-old plus, 65 plus years old. So we're not considering that. In fact, we're just going to lower the dose. Is it like celecoxib? Yes, it is. It is similar to celecoxib. But because they talk about the equivalent dose, we're not considering these options. And rather, we would rather have a lower concentrate or a lower dose of ibuprofen. Okay, moving on to the next question. A 32-year-old man is seen after a recent upper GI hemorrhage that required care in the ICU. Upper endoscopy demonstrates a large cratered gastric ulcer. So they tell you that this is a gastric ulcer. A biopsy of his stomach demonstrates chronic gastritis with evidence of H. pylori. There you go. 1 year ago, this patient was already treated with H. pylori with triple therapy, including PPI, sclerothromycin, and amoxicillin, after he presented with dyspepsia and tested positive for H. pylori. He has no history of use of NSAIDs. Which of the following treatment regimens is most appropriate for this patient? Now, before we even move on to the next slide, I feel like you guys probably already have an idea of what the best possible treatment option would be. He was already treated a year ago for H. pylori with triple therapy. I think it only makes sense for us to step it up to quadruple therapy. Yes, perfect. So let's see. So we have a PPI, we have metronidazole, tetracycline, and bismuth, right? We're not going to repeat treatment because it technically did not really work the first time. We're not really doing the levofloxacin at this stage. It's more so for resistant uh H. pylori and clarithromycin. We prefer to have amoxicillin in that case. What else? Yeah, misoprostol is not part of the quadruple therapy. We're not thinking of that either. And yeah, that's pretty much it. So C is the agents of quadruple therapy. All right. Just a moment. Beginning to take like, oops, okay. A 70-year-old woman with metastatic breast cancer who has received palliative doses of morphine for 2 months is hospitalized with a 2-week history of abdominal pain and distension. Passage of a bowel movement alleviates her pain, although she reports that the stools are quite hard. So she has some sort of constipation, right? Several days of treatment with Senna at home and polyethylene glycol in the hospital has not improved her symptoms. Abdominal examination reveals distension, slight tenderness. Rectal examination reveals hard stool in the rectal vault. Abdominal radiography shows fecal loading throughout the colon. So very obviously she's having constipation, right? In addition to disimpaction, which disimpaction is basically when you are doing a digital rectal exam, right? It's like you put your finger in and you try to take out as much as whatever's impacted in the rectum, right? Which one of the following treatment options is most appropriate to relieve this patient's abdominal symptoms and refractory constipation? It's definitely refractory, right? Because this patient has already taken Senna. This patient has taken polyethylene glycol. And so this is refractory. What do you think is the answer? All right. So the answer is, I think somebody said B, I think. So it's kind of not B. Okay, let me explain to you why. The thing with tramadol is that it's not nearly as effective of a painkiller as morphine is, right? So we prefer not to do tramadol. Um, yeah, so we just want to stick with morphine in this case. But what we're doing instead is we're giving methyl naltrexone. Now, I know methyl naltrexone. I feel like, okay, I know you guys might not even have heard of this drug, and neither had I. But the thing with this is we're giving morphine, right, which is an opioid. And we know this is something that I'm sure is engraved in your brain at this point. It's very high yield to know that opioid overdose is treated by naloxone. So it kind of makes sense that methyl naltrexone is going to counter the effects of the opioid or counter the effects of the morphine on we took it in neuro. Yeah, you're so right. So I'm sure you guys have taken it before. Naloxone. So methyl naltrexone sounds similar to naloxone, and so it kind of makes sense that this would counter the effects of an opioid or counter the effect of morphine, which is why this is the answer. Docusade is not nearly like Docusade is just very docile. It's not heavy duty. Like we need something that's going to cure the refractory constipation. Again, fiber supplementation is not going to do enough. Like definitely these things help with constipation. It's just like not going to be enough. And then next we have magnesium citrate. Which again, that's not going to do a lot either. We need something proper, and in this case, it's going to be um the opposite of morphine, something that will cure or counteract the effects of morphine, which is methyl naltrexone. All right, next question. So a 58-year-old man is brought to the physician by his wife because of a 10-day history of progressively worsening diarrhea and bloating. He has been having 8 to 10 episodes of loose, watery stools every day, including the night. He does not have nausea, vomiting, or blood in his stool. He has a history of cancer, colon cancer, and he just recently started chemotherapy 2 weeks ago. Now, it's important to note here that the chemotherapy started 2 weeks ago or 14 days ago, and he's been having the diarrhea 10 days ago. So this is something to note, whenever you're reading the questions, you should try to always have, especially questions like this. Now, all of my questions actually are from AMBOSS, and AMBOSS gives you step 1 or step 2 style questions, so you really should be familiar with this kind or this stem of a question. You should be able to correlate the 2 weeks of chemotherapy and then the 10-day of diarrhea immediately. Because he also has WPW and he's taking procainamide. Are you thinking, oh, this might be procainamide? No, because he's had it for a while. He's probably had it for years at this point, right? So we're not thinking about that. He smoked 1 pack of cigarettes daily for 25 years. He drinks 2 to 3 beers daily, but quit last year. His temperature is okay. His pulse is a little bit on the higher side. Anything above 100 is high. So he is kind of tachycardic. Which kind of makes sense. If you have diarrhea, being tachycardic is okay because you are dehydrated. So it's expected. It's not normal. It is abnormal, but it is expected. Next, respirations are 22 per minute and the blood pressure is 105/68, which is low. So a lower blood pressure is also sort of in line with your theory that he's dehydrated. He's probably a bit hypovolemic. He has a pale skin with decreased turgor. Capillary refill time is fine. Abdomen is distended with and tender on palpation, and bowel sounds are hyperactive. Laboratory studies show the following. So he has hematocrit of 55%, which is normal. It is on the higher end. It's borderline, but it's okay. Leukocyte count is quite elevated. Anything from 4,500 to 11,000 is considered normal. This is very obviously elevated. The sodium is 149, which the normal is anywhere from 135 to 145. So the sodium is high too. We do have hypernatremia. The potassium is a bit low. 36 onwards is considered the normal range. Chloride, magnesium, whatever, bicarb, glucose. Glucose is fine. Creatinine is fine too. The thing about the hypernatremia, let me just explain to you really quickly, is because of the dehydration. So imagine you have a solution, right? You have a constant number of sodium molecules in that solution, but you remove the water only. If you remove the water only, you tend to get a concentration of the solution, left behind. So that's kind of what happens in our body, is our serum osmolality kind of goes up because you're losing water, you're losing fluid, but you kind of still have the sodium. So that's why there's hypernatremia in this patient. All right, blood and stool cultures are negative. A test for C. diff toxins is negative. In addition to oral rehydration, which of the following is the most appropriate initial step in management? E. Yes, perfect. So, why do you think this is E? Antidiarrheal. It is an antidiarrheal, that's true. Okay, let's talk about why exactly. So, rectal budesonide, that's basically, oh, yes, perfect. Opioid first line. So yeah, oral vancomycin, we're not going to be doing it. Oral vancomycin, vancomycin is given primarily for C. diff. C. diff is negative. Oral rifaximin is more so geared towards traveler's diarrhea or IBS, which we're certain that this patient does not have any of those. Intravenous octreotide is not really, we're not really thinking of that either. Oh, that's true. That's true. So we don't really have a full panel, so we don't really know if it's an infection. Also, they do talk about the fact that the stool cultures are negative, that the C. diff toxins are negative. So we know that it's not necessarily an infection. We know that this is more so um something else. So we're not thinking of those. We're not thinking of rifaximin, vancomycin, etc. Okay. A 35-year-old woman with IBS, now she has IBS, comes to the physician because of increased diarrhea. She has not had any fever, bloody stools, nausea, or vomiting. The increase in stool frequency began when she started a new job. She is started on loperamide, and her symptoms improve. Which of the following is the primary mechanism of action of this drug? We've already talked about this. Yes, perfect. It is A. So it is a mu opioid receptor agonist, basically, and it's going to help with the diarrhea because we know that opioids in general are more geared towards they cause constipation. One of the side effects of opioids is constipation. So somebody who has diarrhea, we want to give them a drug that is, more geared towards making the stool harder or more firmer so that we can stop the constipation. All right, a 44-year-old man comes to the clinic because of a 6-month history of progressive fatigue. He has a history of IV heroin use. Physical examination shows scleral icterus. Study is positive for Hep C RNA. The therapy with interferon alpha is initiated with a combination of a second drug. So interferon is usually combined with something else, especially for chronic hepatitis, as I mentioned earlier, and this patient has a 6-month history of it, right? We were seeing that he has jaundice, which is typical, and the fact that he is an intravenous heroin user, we know that he is a drug abuser, and these people usually do have diseases transmitted by needles, which is hepatitis B, C, HIV, etc. The expected beneficial effect of the additional drug is most likely due to inhibition of which of the following enzymes? B. Yep, you're so right. Ribavirin. So we already talked about ribavirin. We talked about the fact that um inosine monophosphate dehydrogenase is responsible for inhibiting the conversion of IMP to GMP. And when that doesn't happen, you don't really have the GMP necessary for RNA for RNA replication. And because of that, we effectively stop hepatitis C right there. We know that DNA integrase, we don't really need, hepatitis C is an RNA virus. It's not a DNA virus. We don't need DNA integrase. This is more of an HIV thing. RNA-dependent DNA polymerase, once again, is more so an HIV thing. DNA-dependent RNA polymerase, I think, is more important for TB and those kinds of medications. And then DNA gyrase, which inhibits topoisomerase, is not really something that we even considering in hepatitis C infection. Do you understand why it is B? It is ribavirin, like you were right initially, and why it's not C? Does it do both? Okay, so let me just like quickly read it out loud for people that are going to watch the recording. So somebody is saying that it's, I think from the slides, the table in the slide says that it's RNA dependent. That is why it's responsible for inhibiting. How about I answer this fully in the end? Let me just go over this entire concept again, towards the end. Okay, let me go over this in the end. Um, Yes, yes, you're right. Exactly. So I was just gonna mention that actually. I was gonna pull up one of the earlier pictures, and that is RNA-dependent RNA polymerase. Because this is hepatitis C, there is no DNA. It's not a DNA virus. Everything is encoded by an RNA strand. And so, yeah, like this doesn't really work. DNA dependent or DNA polymerase, like these options are invalid because of that. Okay, we'll continue. So let's move on to the next question. A 35-year-old woman that is currently being treated for chronic hepatitis C comes to the physician because of progressive fatigue for 10 days. Previous attempts to treat her hepatitis C infection have been unsuccessful. Examination shows pale conjunctiva. Her hemoglobin concentration is 10, which is quite low. So the normal hemoglobin concentration is 12 to 16 for females, right? For women. Total serum bilirubin concentration is 1.9, which is higher. I think the normal is supposed to be close to 1, and 1.9 is considered high. And then the LDH is 259, which is that is quite high as well. A Coombs test is negative. Assuming her current condition is an adverse drug effect, which of the following mechanisms most likely contributes to the pharmacological efficiency of this drug? So, okay. The fact that she has pale conjunctiva, right, and her hemoglobin concentration is low shows that she has anemia. Now, what kind of anemia are we assuming? The fact that they told us that the bilirubin concentration is high in the blood and the LDH concentration is high as well, which is lactate dehydrogenase, which is an enzyme that's present within RBCs, right? So when you have a hemolytic kind of anemia, the amount of bilirubin would increase, right? There would be some kind of jaundice, and then the LDH is usually quite high as well. Exactly. So we're assuming that this is hemolytic anemia. The fact that the Coombs test is negative, it rules out autoimmune hemolytic anemia, right? So we're not thinking that. Most likely what's been happening is that there's some sort of a drug that the patient is consuming for her hepatitis C that is giving us the hemolytic anemia. Now, if you remember the tables that I showed you in the beginning of the lecture, we actually talked about this. We talked about one drug that causes hemolytic anemia, and it's very specific to it. Which one do you guys think this is? So interferons. No, it's not interferons. So it's actually ribavirin. Decreased synthesis of guanine molecules. So we know ribavirin. We know that. Actually, why don't we just go back to the table really quickly? Here. No, actually, one after. Here. So it says here ribavirin, right? So it talks about the actual agent, and then one of the first ones is hemolytic anemia, and it's in bold. So this just shows us that it's very, very important for us to know that it causes hemolytic anemia and that it's teratogenic as well. Okay, so we're gonna keep this in mind for our exam. Where was I? Yeah. Oh, by the way, I'm going to be sharing the link to this Google document with you guys. I've pretty much explained everything over here. This is from Ambos. Most of my questions are actually from Ambos. A couple of them are from UWorld. And I've already entered the entire explanation here as to why the answer is what it is, right? For you guys. Right. So let's talk about this. Activation of leukocytes, which is interferon, right? Activation of leukocytes produces interferon. We know that interferon has nothing to do with hemolytic anemia, right? Decreased release of progeny virus. This has no place in hepatitis C treatment. None of the drugs that we've studied really talk about this. Inhibition of reverse transcriptase, that's again more so a hepatitis B thing, not a C thing, right? And then we have inhibition of proteases. None of the Provirs, the drugs that we talked about, cause hemolytic anemia. So of course, the first one we're talking about is this. And we know that ribavirin decreases the synthesis of guanine nucleotides by decreasing the conversion of IMP to GMP. And it does that by inhibiting the inosine monophosphate dehydrogenase enzyme. Okay, next question. A 52-year-old woman comes to the physician because of abdominal discomfort, anorexia, and mild fatigue. She has SLE and takes hydroxychloroquine. So SLE, and then we know that there's some sort of a hepatitis B thing going on. We'll come back to this later. She does not drink alcohol or use illicit drugs. Physical examination shows no abnormalities. Serum studies show the following. Her ALT is quite elevated, and her AST is quite elevated too. Both of them are supposed to be close to like 50 to 100, roughly. From what I remember, both of these are quite elevated. So we know that there's some sort of a liver pathology going on, right? If the ALT and AST are elevated. Next, we look at the hepatitis B surface antigen. It's positive. Now, whenever the antigen itself is positive, means that we have a hepatitis B infection. We don't know if it's chronic or if it's acute, but there's definitely an infection. Actually, no, sorry. It is acute. If the antigen is present in the body, it is an acute infection. Then we have the hepatitis B surface antibody, which is negative, and usually this would be positive if you've been immunized against hepatitis B, which I'm assuming that this woman has not been immunized. We have the hepatitis B E antigen is positive, and then the core antigen IgG is positive as well. Again, core antigen being positive and an antibody against the core antigen shows us that, yeah, this patient most likely has an infection, and IgG just shows us that this is most likely chronic. Chronic hepatitis B, yes, you're right. That's exactly the differential. Which of the following is the most appropriate pharmacotherapy for this patient? So somebody is saying C, and you're so right. It is C. Let's go over the options one by one. So it's not pegylated interferon gamma. Remember how I said that this patient has SLE? And SLE is an autoimmune condition, right? In which our immune system is being overactive, is acting against, in this case, it's the double-stranded DNA, right? That's what SLE is all about. So we don't want to give interferon gamma, which technically is immunomodulatory, which means that it's supposed to enhance your immune system. We don't want to give something that's going to make her SLE worse, right? So we're not going to give the interferon gamma, although interferon gamma is used as hepatitis C treatment, but we're not going to give this, right, for SLE. Then we have acyclovir, which that is mostly against herpes and varicella zoster. So it has no role in hepatitis C treatment. Tenofovir, we already talked about tenofovir. It's inhibitor of reverse transcriptase, blah, blah, blah. Sorry, I think I've been talking about hepatitis C. I mean hepatitis B. Sorry. So it has no job in hepatitis B treatment. Tenofovir is a reverse transcriptase inhibitor. We already talked about the way that it works. Dolutegravir is more HIV related. Again, that has nothing to do with hepatitis B. And sofosbuvir is an NS5B inhibitor because of the buvir, and it has no job or no role in hepatitis B treatment. So truly the only answer is tenofovir. All right, next question. So a 45-year-old man presents to established care. He has not seen a healthcare provider in the past year and takes no medications. He has a history of cirrhosis related to alcohol use and has abstained from alcohol for the past 2 years. He reports increased abdominal girth, but no abdominal pain, diarrhea, rectal bleeding, melena, jaundice, excessive sleepiness, or confusion. So he really just has some swelling of his abdomen, which we can say could be ascites since he does have a history of cirrhosis. He is afebrile and has a heart rate of 70, which is fine. Blood pressure is on the lower side. Respiratory rate is 14 is okay as well. And then oxygen saturation of 97% while breathing room air is okay. He does not have any jaundice, pleural icterus, but he does have a few spider angiomas on the chest. And we already know what causes spider angiomas, right? The spider angiomas, palmar erythemas, all of these are because of hyperestrogenism, which estrogen is usually, and also gynecomastia, sorry. All of these are usually metabolized in the liver, and if there's any sort of liver failure or liver cirrhosis, the estrogen does not get metabolized, and because of that, you're gonna have, spider angiomas, you might have palmar erythema, gynecomastia, etc. Cardiac and pulmonary examination was normal. He has mild gynecomastia, there you go. And he has no hepatomegaly, but the tip of his spleen is palpable below the costal margin. He has moderate abdominal distension, shifting dullness, which again, shifting dullness is classic for ascites, as well as leg edema. His mental status examination is normal and there is no asterixis. Now, asterixis tells us asterixis is flapping tremors, right? And that is a sign of hepatic encephalopathy. So by telling us that his mental exam is fine and he has none of the flapping tremors, we are immediately ruling out flapping tremors. The laboratory examination yields the following. All right. Let me move this up a little bit so we can see. All right. So the leukocyte count is normal. The hemoglobin is borderline. That's fine. Hematocrit is okay as well. Platelet count is decreased. So 135,000 instead of the 150 to 350. Sodium is within the normal range. Creatinine is low. Total bilirubin is slightly elevated, which is to be expected in patients with cirrhosis, right? Direct bilirubin is elevated as well. ALP is fine. AST and ALT are okay as well. The INR is, or the international normalized ratio is 0.9, which is normal, I think. Yeah, an INR of 1, actually 0.9 is a little bit low. I think 1 and 1 to 1.3 is considered normal. Testing for hepatitis B surface antigen and hepatitis C antibody are negative. Abdominal ultrasound shows a shrunken and nodular liver with no masses because of the cirrhosis, right? And then we have mild splenomegaly and moderate ascites. A paracentesis reveals a low cell count, low protein level, and serum ascites albumin gradient of 1.4. A gradient of a gradient that's bigger than 1.1 indicates a high likelihood of portal hypertension. So yeah, it kind of makes sense that this patient has cirrhosis, he has portal hypertension, and ascites as well. We did a scope and it showed no esophageal varices. The patient is counseled to continue abstaining from alcohol and is given instructions to restrict his dietary sodium to 2 grams per day. Which of the following is the most appropriate next step? E. You're right, it is E. So let's go over the options one by one. When you perform serial large volume paracentesis, it's mostly for patients that have a very severe ascites, or it's patients that have refractory ascites. This patient, they definitely do mention a more moderate ascites, and he doesn't have, the worst symptoms. He doesn't have esophageal varices, for instance. He doesn't have any hepatic encephalopathy, for instance. So really, it's not very advanced, his disease. So we're not going to recommend even a TIPS right now. A transjugular intrahepatic portosystemic shunt. We're not going to do TIPS. We're not going to do paracentesis. It's more indicated for severe ascites, okay? Prescribe oral propranolol. Propranolol is more so for varices. And again, they do indicate that the patient does not have varices, so we're not thinking about that. Fluid restriction is not recommended actually in patients with cirrhosis. because there's really no use of it. Sodium restriction definitely will help because if you're consuming the same amount of sodium, there will be the same amount of water that flows. If you don't restrict your sodium, but you restrict the water, that's really not going to do much for the patient. And so the answer is E, start oral spironolactone and oral furosemide because we want to get rid of his excess fluid, acidic fluid in his abdomen. And doing or using diuretics is the best way to do that. Okay, next question. A 42-year-old man with chronic hepatitis C infection is admitted to the hospital because of jaundice and abdominal distension. He is diagnosed with decompensated liver cirrhosis, and treatment with diuretics is begun. 2 days after admission, he develops abdominal pain and fever. Physical examination shows tense ascites and diffuse abdominal tenderness. Now there's pain, and there's fever, and there's an ascites, right? Paracentesis yields a cloudy fluid with an elevated polymorphonuclear or a PMN leukocyte count, aka neutrophils, basically. A drug with which of the following mechanisms is most appropriate for this patient's condition? Now, from the question, we can tell that the fact that he has a tense ascites, he has tenderness in his abdomen, he has pain and fever, and now when they did extraction or they did a paracentesis, they saw that the fluid was cloudy, it has leukocytes. We're now assuming that this is SBP, spontaneous bacterial peritonitis, right? And so what kind of antibiotic is the first line treatment? Cephalosporin. So yeah, you're right. Let's talk about the answer. The answer is the of inhibition of bacterial peptidoglycan cross-linking. So basically this is a cephalosporin. This is a third generation cephalosporin. And when you inhibit the bacterial peptidoglycan cross-linking, your was it third gen? Yes, yes, it is. Good job. Okay. We'll go over the other options one by one. So the first, inhibition of bacterial RNA polymerase, that is rifampin, right? Rifampin is more used for mycobacterium. It's used more so for tuberculosis. We're not thinking about it for this patient for spontaneous bacterial peritonitis, right? Free radical creation within the bacterial cell, that is metronidazole. And the most common most common bacteria that's used for metronidazole would be trichomoniasis, Entamoeba histolytica, gardiasis, right? Gardia lamblia, I think. Yeah. And then C, inhibition of the 50S subunit, that's macrolides, sorry, such as clindamycin, linezolid. That is not used for this either. And then lastly, bacterial DNA methylation, that's sulfonamides, basically like sulfamethoxazole, trimethoprim, and that is more so used for UTIs. All right, next question. A 51-year-old man with a history of cirrhosis secondary to hepatitis C virus is admitted to the ICU with fever and abdominal pain. His temperature is 38.3 degrees and his heart rate is 110 beats per minute. His blood pressure is 80 over 40, which 80 over 40 is very low, and his heart rate is high, and he has a fever, right? His abdomen is distended, diffuse tenderness to palpation, concussion of the abdomen reveals shifting dullness. So there you go. We know that it's ascites, we know that he has a fever, we know that he has pain. So the overall question or the stem of the question is very similar to the one that we just did, right? He is oriented to self only with no evidence of a focal neurological deficit. So laboratory investigation yields an INR of 1.6 with the following results. But blood urine nitrogen is elevated, right? Creatinine is fine. ALT, AST is elevated. Albumin is a little bit low, which patients with ascites do have a low albumin usually because the albumin is now within the acidic fluid. Total bilirubin is elevated, definitely. Leukocyte count is high because, of course, the patient has fever, the patient has pain. Most likely spontaneous bacterial peritonitis. Of course, the leukocyte count should be high. Hematocrit is on the lower end, and then platelets are lower as well. Diagnostic paracentesis reveals the following results. A leukocyte count of 550, 70% neutrophils, 1% bad forms, and an albumin level of 0.3 with a total protein level of 0.6. In addition to antibiotic therapy and interventions to increase the blood pressure, Of course, in the ER, you're going to have to normalize his blood pressure. That's one of the first things you need to do immediately. Which one of the following initial treatments should the patient receive for this condition? Yes, okay, I'm just gonna go back quickly. Oopsies. Whoa, whoa. Okay, sorry. So there isn't any hepatic encephalopathy in this patient. They don't mention asterixis. They don't really mention any neurological deficits. There's none of that. So what do you think is the answer? Yes, yes, this is spontaneous bacterial peritonitis because of no, no, don't worry about that. So yeah, it is SBP. Why? Let's go back really quickly. Okay. So the fact that he has a hepatitis C infection, right? He has fever, he has abdominal pain. His abdomen is distended. There's tenderness in the abdomen, and then there's shifting dullness. So the fact that first of all he has hepatitis C, the fact that he has ascites, and now he has painful ascites with fever. When we go to the next slide, actually, they actually mention that the leukocyte count is 550, and 70% of those are neutrophils, which is a lot of neutrophils, right? All of this leads us towards I know that the so one of the things that's necessary for the diagnosis of spontaneous bacterial peritonitis is the fact that your absolute neutrophil count is more than 250. And I know that that's not really given here. But if we were to do a little bit of maths here, girl math, there's a total neutrophil count of 550 per millimeter cube, right? And 70% of those are neutrophils. Half of 550 is going to be roughly 225, right? And we need it to be higher than 250. So the neutrophil count is 70%, which is much more than half. So over half of these, over a half of 550 is neutrophils. So I'm sure that the number is going to be above 250. Does that make sense? So that definitely tells us that the ANC is more than 250, I feel like. Yeah. So, you use a little bit of, you eyeball a little bit to really get a hang of this, and yeah. Oh no, you need to do this kind of stuff. Actually, we have biostatistics on steps. So, this is nothing. Biostatistics, those questions, the biostat questions require like 2 to 3 minutes of calculations, and the amount of time you get per question is a minute and a half. So, you have to steal time from other questions to be able to solve those. I know, girl. It's okay. It's okay. We're in this together, and we're gonna do this. Don't worry. You're gonna be good, inshallah. The answer is D. Good job. So yeah, I feel like I don't really need to explain this. Octreotide is for varices, Midodrine has no impact on ascites, Lactulose is more hepatic encephalopathy. Nadolol is also for varices, like we talked about propranolol earlier. So it's like the only thing that's we really need to use here is albumin because of his very severe ascites. So the two things that you usually use together concomitantly is albumin and antibiotics. And they don't mention antibiotics, so that's the more important thing. And then you give albumin as well. Okay, so how many questions do we have left? 1, 2, 3, 4, and 5. All right, so we're gonna do a couple more because we're running out of time. And then I'm gonna just show you the questions and the answers so you can do them in your own time, inshallah. A 56-year-old woman is brought to the ED by her husband because of increasing confusion, generalized fatigue, and irritability for the past week. She has been unable to recall her husband's name or their address. She has had insomnia and daytime sleepiness during this period. Her last bowel movement was 5 days ago, and she has alcohol-associated liver cirrhosis. Okay, there you go. And now she's presenting with increasing confusion. 1 month ago, she underwent TIPS placement for portal hypertension with refractory large volume ascites. Current medications include spironolactone and furosemide. Yeah, that's usually one of the first line medications given for this condition. She used to drink over a pint of vodka daily, but she quit 2 months ago. She is oriented to time and place. Okay, place and person. All right. not time, just place and person. Her temperature is 37.3, which is fine. Pulse is okay. Blood pressure is on the lower side. Shows jaundice, pleural icterus. She has telangiectasias all over her chest and back, and palmar erythema is present. So she has spider angiomas and palmar erythemas, which these indicate liver failure or advanced liver disease. The abdomen is mildly distended. We're thinking ascites, non-tender, so probably not spontaneous bacterial, right? Peritonitis. There is a flapping tremor on both hands. There you go, outstretched and dorsiflexed. Neurological examination shows no other focal findings. She completes the number connection test lower than the age normalized standard. Which of the following is the most appropriate next step in management? Now, this entire question stem is so huge, but truly the answer is so simple. And if you were to just read the flapping tremors, I think you could have easily gotten this. What do you think is the answer? D. You're right, it is D. So reversal of tips, we're not really gonna do that because then you're gonna get decompensated liver cirrhosis, and we don't want that. We don't want to do another sort of procedure, another operation, especially when the patient has hyperammonemia, right? She clearly has flapping tremors. She's clearly in this kind of a place. We don't want to do more procedures on her right now. Therapeutic paracentesis, her abdomen, they do mention, is mildly distended, which is not too bad. We talked about how paracentesis is usually reserved for larger volumes of ascites. IV ceftriaxone, no, we're not. There's no spontaneous bacterial peritonitis. Metronidazole, there's no job for that. And lorazepam, not really. That's not the treatment for hepatic encephalopathy, so we're not going to even consider that. Okay, next question. A 36-year-old man is brought to the emergency department by his girlfriend because of increasing confusion for the past 6 hours. He drinks large amounts of alcohol daily and occasionally uses illicit drugs. He is lethargic and oriented only to person. Physical examination shows jaundice, hepatomegaly, and scattered petechiae all over the trunk and the back. Neurological examination shows normal reactive pupils and a flapping tremor when the wrists are extended. A drug with which of the following mechanisms of action would be most appropriate for this patient's condition? B. Yep, you're so right. Excretion of NH4. So, hold on. Yeah. So, which drug do you think causes the excretion of NH4? Lactulose, perfect. So the way that lactulose works, let me just quickly give you a quick overview. Lactulose basically gets converted to lactic acid in our colon or in our gut, right? Lactic acid is an acid. We know that hepatic encephalopathy is caused by hyperammonemia because the liver is not able to clear enough away from the blood, right? So we have NH3, which is ammonia. This is not an ion. This is just a molecule, right? So when we have lactic acid in we take lactulose, converts to lactic acid. Now we have an excess of acid, an excess of hydrogen ions, right? This hydrogen is going to go and bind to ammonia and make it NH4 plus. Now it is a cation, and cations or ions in general are very absorbable, so it can be excreted just as quickly. Whereas ammonia does not get excreted as quickly because it's not absorbable, right? Excretion of free iron, production of ammonia is this is the cause of the encephalopathy, right? Why would we want that? Production of glutathione, inhibition of the mu receptors, no. None of these are important. The only thing we want to do is excrete ammonium ions. All right. 50-year-old man with cirrhosis secondary to non-alcoholic fatty liver disease presents for a follow-up visit 2 weeks after hospitalization. This is the last question we'll do, and then I think the rest of the 3 questions, I'll just show them to you guys, and then you can do them in your time, inshallah. Yes, so he presents for a follow-up. He presents for a follow-up 2 weeks after hospitalization for current hepatic encephalopathy. He had one prior admission for hepatic encephalopathy 6 months ago. During his most recent hospitalization, he had mild hypokalemia, which was corrected, and additional lactulose was administered. He improves within 2 days and was discharged home on furosemide, potassium supplementation, and lactulose 3 times a day. At today's visit, he feels a lot better. His complaint is insomnia. A family member notes that the patient is having some difficulty concentrating and that he seems sleepy during the day. In addition to the continued use of lactulose, which of the following treatments is most appropriate for this patient's current hepatic encephalopathy? What do you think is the answer? D. Okay, let's look at D. You're right. So it is D. Um, Yeah, so let's go over them one by one. A probiotic's not going to do anything. Neomycin is an antibiotic. It has no role in hepatic encephalopathies. Non-selective beta blockers, more so for varices, right? We're not really thinking about it for hepatic encephalopathy. And a dietary protein restriction could potentially, like, I know in theory it feels like it could work because you're not going to have as much protein, you're not going to have as many amino acids, or you're not going to have, the urea cycle is not going to work as hard because of in the liver, and you're not going to have as much ammonia. And I feel like in theory you could feel like it works, but truly, like, it's not going to have that big of an impact as much as rifaximin does. And the combination of lactulose with rifaximin is perfect. That's what's going to work best here. All right, just give me one moment. Let me come back. Oh yeah, again. All right. So again, I've already added all of the explanations for each of the different questions in the box at the bottom, and you should be sent these slides very soon, inshallah. We only have two more questions left, which I added already. Just like I just added them to be extra. No, not to be extra. I don't want to be extra, but just an extra question for you guys. So yeah, here's the question. The explanations right here. Let me open it up for you guys so that you can access it even through the recording. And yeah, I think pretty much we've already covered the most important topics. Hold on. So once you've read the question, you can pause, read the question, you know the answer, and here's the explanation. All right. And that pretty much concludes our session. Okay. That pretty much concludes our session. Thank you so much for, sticking around. And I hope, inshallah, I was able to help you guys. Even if I helped you learn one new thing today, I think honestly that would make me so happy. Here's the QR code which you can scan. There should be a form which you can fill to evaluate me as a tutor. And yeah, I would be very, very happy if you could let me know what you thought of the session. It could be anything. It could be a constructive criticism. It could be something good, something bad, anything that I can improve on in the future. I would appreciate it, honestly. And that's pretty much it. Thank you so much for, sticking around. And yeah, good luck on your exam. I hope you guys do really well, inshallah.